Welcome everyone to This Explainer. I am absolutely thrilled to have you here today. Get ready, because we're exploring what might just be the body's ultimate, finely tuned chemical factory, the adrenal glands. We are going to map out exactly how this incredible system works, and crucially, what happens when it malfunctions. Here is our roadmap for today. We're going to meet the adrenal glands, look at their hormones and control systems, and then explore disorders of excess, disorders of insufficiency, and finally, the adrenal medulla.
Think about this for a second. How is it possible that an organ weighing just 4 grams, literally about the weight of a sheet of paper, has the absolute power to control your blood pressure, your metabolism, and your entire physiological response to stress? It's truly mind-blowing. Today, we're going to see exactly how it pulls that off. Section 1. Meet the adrenal glands, the factory layout. Okay, let's dive into this. You've got 2 of these little pyramidal-shaped glands sitting right at the upper poles of your kidneys, level with the 12th thoracic vertebra. If you were to slice one open, you'd see it has 2 completely distinct parts, an outer yellow portion called the cortex and an inner gray core called the medulla. Now, what makes this organ so incredibly efficient is its blood supply. It actually has the highest perfusion of blood per gram of tissue in the entire human body. Why? Because the second it manufactures a hormone, it needs to dump it straight into your bloodstream for rapid systemic dissemination. Section 2. Hormones and control systems. The production lines. The outer cortex is divided into 3 distinct layers, and there's a perfect mnemonic to remember them: salt, sugar, sex. The outermost layer, the zona glomerulosa, makes up about 15% of the cortex. It produces aldosterone to control your body's salt and water balance. The middle, massive layer, the zona fasciculata, makes up 75% and produces cortisol. That's your primary sugar and metabolism regulator. Finally, the innermost layer, the zona reticularis, makes up the last 10% and produces androgens like DHEA for sex characteristics. Salt, sugar, sex, it sounds like a pretty wild weekend, but it perfectly maps out your adrenal factory floor. Now, the master circuit board controlling that sugar production line is the HPA axis. When you experience stress, whether that's emotional trauma, low blood sugar, or even just cold temperatures, your hypothalamus releases CRH. That signals your anterior pituitary gland to release ACTH, which then screams at the adrenal cortex to pump out cortisol. And brilliantly, just like a smart thermostat, once those cortisol levels get high enough, it loops right back up to the brain to shut the signal off through negative feedback. But what about the salt line? Well, that's managed by the RIAS feedback loop. If your blood pressure drops or your sodium levels fall, your kidneys sense it immediately and release an enzyme called renin. Renin kicks off this whole chain reaction involving your liver and your lungs, ultimately creating angiotensin too. This powerful molecule then directly orders the adrenal factory to release aldosterone, which basically tells your kidneys to retain sodium and water. And boom, that drives your blood volume and blood pressure right back up. Section 3. Disorders of excess. The factory in overdrive. So what happens when factory management totally fails and starts churning out way too much product? When the adrenal factory is stuck in overdrive producing excess cortisol, we get Cushing syndrome. Because cortisol affects pretty much everything, the symptoms are completely multisystemic. Patients experience significant weight gain with visceral obesity, profound muscle atrophy, because remember, cortisol breaks down protein, bone loss, immunosuppression, and severe hypertension due to cortisol's secondary salt-retaining effects. It is a devastating systemic overload. Now, what's really interesting about this detective work is figuring out exactly where the hyperfunction is coming from based just on hormone levels. If a patient has a pituitary tumor, both ACTH and cortisol are high, but a massive dose of synthetic steroid, dexamethasone, will actually suppress it. If the ACTH is coming from a rogue lung tumor, though, it won't suppress at all. But here's the twist. If the tumor is right there in the adrenal gland itself, it acts completely autonomously. It pumps out high cortisol, which shuts down the brain's ACTH production, meaning ACTH will be basically flatlined. Because the system is so complex, diagnosing Cushing's is an escalating investigation. We don't just guess. We follow a rigorous step-by-step logic. First, we screen. We administer a low dose of dexamethasone overnight just to see if the factory can be quieted down at all. If it can't, we escalate to step 2, confirming the excess, through an insulin tolerance test or a high-dose test. And only after we know for certain there's a problem do we move to step 3, identifying the culprit by measuring ACTH and firing up to CT or MRI scanners to hunt down the tumor. All right, let's shift from excess sugar to excess salt. Primary hyperaldosteronism, often called Conn's syndrome, happens when an adrenal adenoma, which is a benign tumor, starts pumping out massive amounts of aldosterone. Remember, aldosterone tells the kidney to hold on to sodium, so these patients present with incredibly high blood pressure, high sodium, and dangerously low potassium. Interestingly, because the factory is acting on its own, the kidney frantically tries to shut the system down, resulting in completely suppressed renin levels. To prove the factory is acting autonomously in Conn's syndrome, we use dynamic testing. We screen by checking the ratio of aldosterone to renin. Then, we essentially try to trick the body. We give an ACE inhibitor like captopril, or we pump the patient full of 2 liters of saline. In a healthy person, this massive fluid volume load would tell the adrenal gland to immediately stop producing aldosterone. But in Conn's syndrome, the adrenal gland completely ignores those physiological signals, and aldosterone stays dangerously high.
Section 4. Disorders of insufficiency, factory shutdown.
So the crucial point here is understanding the difference between the gland itself failing versus the brain failing to send the signal. In primary insufficiency, or Addison's disease, the adrenal gland is physically destroyed, usually by an autoimmune disease. Because there's no cortisol, the brain screams for it, resulting in sky-high ACTH levels. That excess ACTH stimulates melanocytes, causing a really unique tanning or pigmentation of the skin. They also lose their aldosterone, causing life-threatening salt wasting. Secondary insufficiency is completely different. Here, the pituitary just isn't sending the ACTH signal. Because the problem is low ACTH, there is no skin pigmentation. And because aldosterone is managed by the kidneys and RAS, not the pituitary, their salt balance is completely normal.
To test for a factory shutdown, we use the short-synapthin test. Basically, we inject the patient with synthetic ACTH, essentially hitting the go button on the factory ourselves. If we measure their cortisol levels and they don't rise above a baseline threshold, we know the adrenal factory is structurally incapable of responding. It is officially offline.
A genuinely fascinating cause of insufficiency is congenital adrenal hyperplasia. This isn't destruction of the factory. It's actually a genetic missing part. 90% of the time, an enzyme called 21-hydroxylase is missing. This creates a massive bottleneck. The body tries to make cortisol, gets stuck, and the brain sends more and more ACTH trying to force it. Because the sugar and salt lines are blocked, all those raw precursor materials are forcefully shunted down the only open path, the sex line. The result? A severe lack of cortisol and aldosterone, leading to salt-wasting crises, but massive amounts of excess androgens, causing virilization and ambiguous genitalia in newborns.
Section 5. The adrenal medulla, the inner core.
Finally, let's travel away from the cortex, deep into the inner core of the gland, the medulla, home of our fight or flight response. The medulla is made of specialized neural crest cells called chromaffin cells. When a tumor forms here, it's called a pheochromocytoma. Instead of steroids, this tumor secretes excess catecholamines, adrenaline and noradrenaline. The symptoms are dramatic. The medulla essentially dumps buckets of adrenaline into the bloodstream randomly. Patients experience abrupt, paroxysmal, meaning sudden violent spikes in blood pressure, racing heart rates, intense sweating, severe headaches, and a profound sense of apprehension or doom. We catch it by looking for the broken-down metabolites of adrenaline, called metanephrines, right in the urine.
Let's move to and see how this builds. To remember the behavior of these rare medullary tumors, medicine uses a classic heuristic, the rule of tens. 10% occur outside the adrenal gland entirely, 10% happen in both glands simultaneously, 10% are actually malignant cancers, 10% are linked to inherited genetic syndromes, and 10% show up in children. It is a remarkably clean way to organize the pathology of a very, very chaotic tumor.
Which brings us to the end of our journey through this incredible organ. If a tiny 4-gram chemical factory sitting above your kidney can completely alter your weight, dictate your blood pressure, shut down your immune system, or plunge you into a state of sheer physiological terror, it really makes you wonder, what other hidden physiological systems are quietly running your life right now? Keep asking questions, keep learning, and I'll catch you in the next explainer.